Today we're going to discuss pulmonary edema. Remember that edema is the increase in fluids within the interstitial space. Pulmonary edema is that, but we also have increased fluids that go into the air-filled sac or the alveolar space. The two major causes are cardiogenic and non-cardiogenic. For non-cardiogenic, this could be fluid overload, and it can also be ARDS or acute respiratory distress syndrome. When we talk about ARDS, we talk about direct lung injury and indirect lung injury. So an example of a direct lung injury could be a near drowning or a chemical burn injury where we're inhaling chemicals subglottic into that airway and we cause damage to the alveolar, causing an inflammatory-like reaction. An indirect injury could be sepsis or pancreatitis, where there's inflammatory reaction going on within the blood vessels, and those inflammatory mediators cause damage to the alveoli. When we talk about net filtration, that's how we get the movement of fluid back and forth across the capillary wall. So we best describe this using the Starling hypothesis, which is really describing the forces that move fluid from the arterial side into the interstitial fluid and then back on the venous side. So those forces will be our hydrostatic and our oncotic pressure. So our hydrostatic pressure will push fluids out on the arterial side, go into the interstitial space, and this is where we would have edema if it sat there, but it gets reabsorbed on the venous side because of oncotic pressure. The oncotic pressure comes from proteins in the plasma, in the blood. Those proteins should not be leaving the blood, so we have a constant pulling effect to get fluids back into the blood. A good example of a plasma protein will be albumin. Some of the fluid that's in the interstitial space will then also be absorbed and filtrated out by the lymphatic vessels as well. So as you can see, when we have alterations in these, we can have increase in fluid. So if we had an increase in capillary hydrostatic pressure, a decrease in capillary oncotic pressure, increased capillary membrane permeability, or if we had obstruction of that lymph vessel, all those things can lead to accumulation of fluid inside the interstitial space and eventually within the alveoli. So one of the first causes of pulmonary edema would be increased hydrostatic pressure. You can see increased hydrostatic pressure with cardiogenic pulmonary edema. So as we're pushing more fluids, we're getting this accumulation of fluid in the interstitial space now. And this pressure can be high enough that even though the lymph vessels are draining the fluid, it can be at a higher rate, so it's overpowering the lymph vessels. Another cause would be loss of oncotic pressure. Again, the oncotic pressure is the pulling pressure that brings the fluid back into the blood on that venous side. The pulling pressure comes from the proteins in the plasma. Usually those proteins stay within the plasma, but if we're wasting the proteins or we're losing them, or we're not making enough, then we will lose that pulling effect. Therefore, when fluid's pushed out, it's less likely to be reabsorbed on that other side. Therefore, it's going to accumulate in that interstitial space. Another cause of edema would be increased capillary permeability. We have increased capillary permeability from secondary inflammation. The inflammation can be from trauma, infection, or anything to cause inflammation. When this happens, the walls of the capillaries become more leaky. Therefore, they allow proteins now to leak out into our interstitial space. And remember, those proteins will give us that nice oncotic pressure to pull fluid back into the plasma. Therefore, the fluid wants to follow those proteins into the interstitial space. Other things that accumulate are white blood cells, which are great for fighting off infections and other things like that for inflammation, but they can actually cause damage to that alveoli wall. So now our fluid is getting pulled into the interstitial space. So let's talk a little bit more about ARDS. So ARDS, or non-cardiogenic pulmonary edema, can be direct lung injury or indirect lung injury. What I mean by that is actual injury to the alveoli itself, or a process that's causing damage to the alveoli coming from the systemic circulation. So for instance, that could be sepsis. So with sepsis, our capillaries throughout the body become leaky. Therefore, we're leaking fluid into the interstitial space, and we're also leaking white blood cells and proteins and other things that we talked about before. Those white blood cells can cause damage to the alveolar membrane, the actual wall of the alveoli. It can cause damage to that wall. When that occurs, as you can see on the illustration, we have an open passageway for fluid to accumulate in the alveoli. So that's one way that pulmonary edema is going to occur. Those white blood cells, I should add, also kill off type 2 pneumocytes. And type 2 pneumocytes are part of the alveoli. We have type 1 and type 2 pneumocytes. Type 2 pneumocytes make surfactant, which is helpful for reducing surface tension. So if we kill off our type 2 pneumocytes, therefore we increase our surface tension and eventually lead to collapse of the alveoli. So let's talk about direct lung injury. So here, let's say pneumonia is in this alveoli here. When that happens, the pneumonia is going to attack the alveoli. It might attack those type pneumocytes again. It's going to cause damage. When that happens, damage leads to inflammation. So inflammation is going to bring white blood cells again, and those white blood cells are going to do what they do best and try and help out, but they might cause more damage to the alveoli, thus leading to increased fluid accumulation. Near drowning can also occur where the fluid actually comes in and washes away that surfactant. Therefore, that can lead to alveolar collapse. Whether it be direct or indirect lung injury, what I'm trying to say is that there's some injury to the alveoli, which leads to an inflammatory process, which can lead to capillary permeability increase and accumulation of fluid. Each of these processes can be unique, but I'm giving a broad and general idea of how this occurs. So let's talk about some of the signs and symptoms we're going to see with pulmonary edema. Now, yes, these signs and symptoms can vary according to the disease process that's causing the pulmonary edema, but things like shortness of breath and difficulty breathing and hypoxemia should be present with both. And why are we having this hypoxemia? Well, it's coming from a VQ mismatch. And again, remember, VQ mismatch is one of the number one reasons we're having hypoxemia in any of our patients. This VQ mismatch comes from a low ventilation VQ mismatch, meaning we're not ventilating the alveoli and we can't get oxygen into the blood. Our perfusion is okay, but our ventilation is the problem, a low VQ mismatch, which we can also refer to in this circumstance as a shunt. The oxygen is having issues diffusing because there's fluid and protein and other things in the way, so it makes it difficult for that oxygen to get past the alveoli and into our pulmonary circulation. So therefore, that blood is passing through the capillary and passing through the alveoli and not picking up as much oxygen as it should. So this is where we get this mixing of deoxygenated blood that's going into the circulatory system, because we're coming past and not picking up the amount of oxygen we need. I should add that with shunt or this low VQ mismatch, just simply adding on supplemental oxygen might not increase our blood in the arterial circulation, because that oxygen is still going to have a problem diffusing through all this fluid and all the other things occurring in that interstitial space and in the alveoli. So what we need to do is fix the problem that's causing the pulmonary edema. We also might need a degree of positive pressure ventilation to help redistribute those fluids and help the alveoli get into the pulmonary circulation. What about CO2? Are we having any hypercapnia with these patients? Usually we're not, because CO2 is about 20 more times soluble in water than oxygen is. Therefore, it does not have an issue diffusing through all of this that's occurring. Some of the other signs and symptoms we can get with pulmonary edema are the classic breath sounds. So one would be the crackles. And again, that's usually the popping open of the alveoli that are fluid filled and or collapse. The other thing we can get is a wheeze, which is kind of referred to as that cardiac wheeze. And this occurs, remember again, wheezing occurs as air goes through a airway and there's a degree of change in the patency. We get this vibration, which causes that sound that we hear, that high-pitched wheeze. It's causing vibration as it goes through a change in patency in one of the tubes of the airway. Well, this occurs with pulmonary edema because we have increased fluid accumulation outside of the vasculature into the interstitium. And that's not just occurring by the alveoli, it's also occurring in the vasculature of the bronchioles. So those bronchioles will then get thickening. The wall of the bronchioles become thick because the vasculature is leaking fluids into that interstitium, causing thickening of the bronchial wall. So when air is going to come through, it's going to cause that vibration and we're going to get that wheeze. So air normally comes through a nice patent tube with no issues. But when we have thickening of this wall of the bronchiole, we're going to get that vibration and we're going to get that famous cardiac wheeze. So next we'll talk about the diagnosis of pulmonary edema. What I want to show you first is how this edema, hydrostatic edema or cardiogenic edema, goes in phases. Okay, because it's those phases that also correlate with some of the findings you're going to see on chest x-ray. Okay, so for instance, our cardiogenic edema usually starts by redistribution of our blood flow, which means we just have dilation of the vasculature. Okay, and we're usually going to see this in the apices of the lungs because the apice lung vasculature is usually smaller than in the bases. Then as that hydrostatic pressure continues to increase, we're going to get fluid in the interstitium. Okay, so interstitial pulmonary edema. Last, we're going to get the pulmonary edema of the airway themselves, of the alveolar pulmonary edema. Okay, so I just want to make a note of that because if you're going to study or if you're going to work in the ER or the ICU and you see the radiologist, sometimes they refer it as that because this occurs in phases. So the pulmonary edema from the cardiogenic phase can be in different phases of how bad the edema is, and some of the findings on the chest x-ray are related to the certain degree of pulmonary edema occurring. So let's move forward. So one of the things we can see is curly B lines, which are these longitudinal lines we're going to see in the periphery of this lung chest x-ray. So we usually don't see the vasculature on the outer periphery here of the chest x-ray. Usually we can't march it out that well. So we can see these lines here, and also on the right-hand side, you can see them as well. We're usually going to see our curly B lines more in the bases of the lung rather than in the apices. So curly B lines are thickening of the interlobular septa. Okay, so the interlobular septa is right here. And what's in that interlobular septa is our veins, our pulmonary veins, and some of our lymphatics. So we can see this line here when there's edema, right? When there's edema within the lymphatic and the veins here. Okay, that's why we can see these nice longitudinal lines on chest x-ray. The edema causes fluid into this interlobular septa, which then makes it more identifiable and more prominent. We usually don't see these curly B lines because there's usually no edema in this area. Okay, that's why they're easier to see. So within here we have our alveolar pulmonary artery and a pulmonary vein, but within this septa is going to be our veins and lymphatics. And when they're when there's edema in this area, we can see it better on chest x-ray, which is what we call our curly B lines. Another thing we can see is this cephalization, which would be this vasculature here at the apices. And basically what's happening is the vasculature in the apices is becoming more visible when compared to the vasculature here in the bases. Usually on a normal chest x-ray, you should be able to kind of see this vasculature in the bases. It's more prominent when compared to the apices. So this would just be that redistribution of blood. So we can just see these a lot better. They're kind of standing up for us. We can see them a lot better because they're starting to dilate because of the increased fluid. So that's kind of one of those first things we talked about. So we can kind of see that here as well. Personally, I think it's very difficult to see unless you have a previous chest x-ray to compare it to, which is always helpful when reading any chest x-ray. And then kind of once we get that get that edema in the alveoli, then we can kind of get that classic bat wing appearance, which is that perihilar haze. So we get that kind of that fluffiness here in these areas, and it's kind of looking like a bat wing. So let's talk about diagnosing cardiogenic from non-cardiogenic pulmonary edema. So if we're simply looking at the chest x-ray, One of the things we can look at is the cardiac size. If the heart is enlarged, it's more likely to be a cardiogenic pulmonary edema cause. Other things would be pleural effusions. If we have pleural effusions with our pulmonary edema, it's more likely to be a cardiogenic cause. Because remember, the heart can cause pleural effusion by almost the same mechanism. We have that increased hydrostatic pressure, which then causes fluid to accumulate in that pleural space, which would be a transudative pleural effusion. Also, curly B lines are more likely to be present with our cardiogenic pulmonary edema rather than our non-cardiogenic. We can obviously always use ultrasound to look at the function of the heart, but the big thing is going to be that patient history. Obviously, if that patient isn't super sick, they can tell you the events that led up, or EMS can tell you the events that led up to the respiratory distress and ultimately pulmonary edema. But if the patient comes in and you don't have any history on them and they're super sick and everything, then it becomes a guessing game trying to figure out non-cardiogenic from cardiogenic pulmonary edema, and having these tools and knowing your resources and knowing your tools is helpful to decipher the difference of them. Ultimately, what we can do if we have kind of this mixed picture is we can float a swan gaze catheter. When we float that swan gaze catheter, it's usually going to be floated from the right internal jugular vein. It's going to go through this superior vena cava, right atrium, right ventricle, into the pulmonary artery, and then sit in one of the primary branches that comes off the pulmonary artery. Then what we do is we call it wedging, or we inflate the balloon. When we inflate the balloon, we get an indirect measurement of the pressures coming from the left side of the heart, because we're inflating that balloon. And at that point, I'm getting the pressures from in front of that balloon, which are going to be the left side of the heart. We're in front of the balloon now, and we're going to get equalization of those two pressures. So I want to get the pressure from the left side of the heart. And it's an indirect measurement because we inflated that balloon. When we're looking at these values, we're looking at a pulmonary capillary wedge pressure of less than 18. If it's less than 18, it's more likely to be a non-cardiogenic cause. If it's greater than 18, more likely to be a cardiogenic pulmonary cause. I should add that it's not always black or white. You can have a mixture of these things. For instance, if you have a trauma patient and you're resuscitating them with a ton of fluids, a ton of product and everything like that, well, they have a bunch of trauma. So they're going to have that inflammatory reaction that I talked about. So we have increased permeability, but you also give them a ton of fluids. So now their hydrostatic pressure and that pushing pressure is going to be higher as well. So you can have a mixture of these things. So it's not always black or white which one you're dealing with. You can have a different etiologies causing ultimately the pulmonary edema, and figuring out the cause will help you with your treatment. When we talk about treatment, it's going to depend on the underlying cause of the pulmonary edema. The biggest thing is treating the underlying cause to cause less pulmonary edema. But there are general rules for pulmonary edema. For instance, fluid management. We want to keep these guys pretty euvolemic. Not all your patients are going to be fluid overload causing the pulmonary edema. So knowing your fluid status is going to be helpful. Because if you give diuretics to a patient in cardiogenic pulmonary edema, he might actually be dry and need more help on the pump side than decreasing his stroke volume. So relative euvolemia is great. Now, the question of how to oxygenate these patients. Well, we talked about that we're dealing with a low VQ mismatch. So simply putting them on a non-rebreather or nasal cannula might not work that great. We need a degree of pressure to help these patients out. So something like high flow nasal cannula, which everyone kind of talks about how much CPAP or pressure you're getting, is always an argument, but there is a degree, so that could be helpful if using it correctly. But if these guys are sucking for air and their mouth is open, you might not be getting the pressure you want. So something like non-invasive positive pressure ventilation like BiPAP or CPAP are ultimately needing intubation. But positive pressure ventilation is super helpful because it's going to increase that surface area and help redistribute those fluids. That way, when we redistribute those fluids, we can get the oxygen to cross in to the vasculature and start to help out our hypoxemia. If you get to the point where now we're ventilating these patients, we're usually going to use our ARDS-NAT protocol. In a idea of ARDS-NAT protocol, we're going to go into it, but really, if you just remember anything, low tidal volume, high rate, high peak. But it's way more complicated than that. So, biggest thing when we talk about volume is we're shooting for a 6 cc's, well, to start, 6 cc's per kilogram of ideal body weight. That's because higher levels of volume will cause overstretching of those alveoli. And I told you before, if we overstretch those alveoli, we lead to damage. And like I said before, damage leads to inflammation, which leads to pulmonary edema, and we're back to square one. So let's not keep doing that. So if we do the 6 cc's per kg, that's a good start. But because we have a lower volume, we need to increase our rate because we still want these guys to have a good minute ventilation. Remember, your minute ventilation is your tidal volume times your respiratory rate. So we want to give them a higher rate, but we want to be careful and not go too high, as in above 35 according to protocol. As we're giving them volume, we want to watch our P-plats. In an ideal world, they want your P-plats less than 30. Now, that's not always going to happen with the sickest people, but that's what we want to shoot for, less than 30. And if we're not hitting that, we're going to reduce our tidal volume by 1 cc until we get all the way down to 4 cc's. That's the lowest you'll go, right? So you can do 5 cc's per kilogram of ideal body weight for your tidal volume. And then if that's not working, go down to 4 cc's per kilogram for tidal volume. Okay. When we talk about our PEEP in FiO2, according to protocol, we're looking for an SpO2 of 88 to 95 and a PaO2 of 55 to 80. And as you can see on the slide here, as your FiO2 goes up, your PEEP will go up greatly. And we want to use that because it's that PEEP, it's that pressure that these guys need. We need the oxygen to follow. Once we open them up, we need oxygen still moving. But you can throw a lot of oxygen. They need something to pop them open, redistribute those fluids, open them up, give them a nice pathway into the vasculature. So you can't not give them oxygen because once we open up the bridge, we got to get people in there. But they need a way to get in there. And that's where that pressure is everything here. So that table is why it's so helpful. When we look at our pH, we have a little bit of permissive hypercapnia with these patients. We're a little bit more leeway with them because our tidal volumes are lower. So that's where you can mess with other settings and rate and stuff like that to try and bring it down, but we don't worry about it too much. But we do want to keep our pH above 7.2, right? We want to keep our pH in relatively good standing for the patient to help them get better, okay? When we talk about sedation and paralysis when it comes to ventilation of these patients, that is sometimes something that happens because these patients are so sick. And if they're trying to help us, it's not working. They almost sometimes need rest on the vent. But don't just throw a bunch of sedation at them because if they're super sick and their pressure's low and they're already on a bunch of vasopressors and maybe inotropes, and then you give them a bunch of propofol or other stuff like that, now we're just in a circle. We're in a circle here. So this is where your RTs are the best. Shout out to Respiratory Coach and other medical providers that are getting the vent down. Because this is where you can help with synchrony of these patients, make them more comfortable. Okay. So you're changing things like their flow and their trigger and stuff like that. And you're helping them get more comfortable on the vent. So maybe you don't need as much sedation. Now, I'm not giving anyone advice here, but this is where it comes into, sometimes they just do need sedation though as well. Sometimes these guys are just sick enough where they need to be paralyzed and sedated, taken out of the equation and let their lungs rest. Well, we let the vent do the work. Once we get to the bigger stuff, we have APRV, we have bilevel ventilation, all these crazy things where we're using these inverse IDE ratios. So we're giving more I time, right? We're giving more inspiratory time. So we're giving more time for all those oxygen to run in and get into the plasma. Okay. We can also prone these guys, which obviously was really popular with COVID, but it was always popular before too. So proning is very helpful here as well. And then ultimately ECMO. If we cannot properly get these guys oxygenated, would be a option in the end. A couple last things I wanted to add is how great positive pressure ventilation can sometimes be helpful and how great it can be to our sicker hearts that are having cardiogenic pulmonary edema. So, for instance, our positive pressure ventilation can reduce preload. How it does that is it increases our CVP, which gives less venous return. So if we have already less venous return to the right side of the heart, we have less blood moving forward to the left side. Another thing is we see increased RV afterload, right? Because we have all this positive pressure in the pulmonary circuit, it's going to cause more afterload for the right ventricle. So therefore, it's giving less blood over to the left ventricle. So there's another reason we're decreasing preload. And lastly, once we have this increase in our right ventricle afterload, we get this high right ventricular end diastolic pressure. So that pressure in there is getting higher and higher, which causes this leftward displacement of the septum. So we even get less preload into the left ventricle. So it can be helpful there as well. Positive pressure ventilation or non-invasive positive pressure ventilation also helps decrease our afterload. And how it does that is the LV is constantly having an afterload of the wall tension of the left ventricle. So how do we reduce that wall tension? Well, if we're giving PEEP and positive pressure, it's actually helping to squeeze the LV. It's helping to push the left ventricle. It's giving it support against its own wall tension. Because of the increased pressure in the interpleural and interthoracic space, that increased pressure actually helps push that heart. It's giving it help. So it's working against its left ventricular wall tension, therefore reducing its afterload. So some of these patients just need a little bit of non-invasive positive pressure ventilation and something else to decrease their afterload like nitro. And they can ultimately help out their cardiogenic pulmonary edema so much and not need intubation. That's all I have for you guys. I know that was a lot of information. Reach out to me if you have any questions, and I hope to hear from you guys soon. Thank you.